today's lecture, we are going to discuss the cardiovascular system and some of the diseases that are associated with the cardiovascular system. Today we'll specifically look at some of the basic pathophysiology associated with congestive heart failure and hyperlipidemia. We will also look at some of the therapeutic measures used to help treat these conditions, some of the drugs associated with these conditions, and some of the properties associated with those drugs. And then we'll wrap up talking about some of the perioperative management of these patients with some of the common cardiovascular disease processes. We're going to start looking at congestive heart failure. And this slide really kind of helps to illustrate the progression, or the common progression of some of the common cardiovascular disease processes. You can see at the very top, we start with hypertension and atherosclerosis, which is relatively common. And then as those disease processes worsen, then we can progress to myocardial ischemia, where we're essentially starving the heart from adequate blood flow, and then obviously that can progress to infarction, where we essentially cut off the blood flow entirely to the myocardial tissue. And then as a result of death and scarring from the myocardial event, we can have a basically myocardial tissue that is unable to contract like normal, and that can lead to heart failure. So looking more at heart failure specifically, remember that the heart essentially is a pump, and that's its primary job. And so when we have heart failure, essentially what we have is pump failure. Obviously, when we have heart failure, what we're talking about is failure of the myocardial tissue itself. So we're talking about the heart muscle is not able to contract like normal. And so whenever we have a heart that's unable to contract like normal, that can lead to insufficient cardiac output. And essentially what we have with time is the heart is unable to meet the demands of the body. And so we have the body essentially is starving of the oxygen because the heart is unable to kind of keep up with those metabolic demands. When we talk about congestive heart failure, often this is kind of a garbage can term that's really used more to describe the clinical findings that we see. Some of the clinical findings include shortness of breath, and that really results from a complete decrease in cardiac output. The heart essentially can't pump and move blood around as efficiently as it normally can, and so that essentially with exertion or increased metabolic demands by the rest of the body, the heart can't keep up, and so we start to see the signs that go along with that. So we see a decrease in exercise tolerance, once again shortness of breath. We can see some other things depending on what type of CHF that we have going on. Congestive heart failure really can be primarily involving the left side of the heart, the atria, and primarily the ventricle. It can also involve the right side components as well. Once again, the ventricles more so than the atria. And it can also involve both aspects, both the right and left sides of the heart. So looking at left-sided heart failure, essentially what we have is inadequate function, primarily involving the ventricle, but it could also be the atrium as well, of the left side of the heart. And essentially what we have is because the ventricle, the left side of the heart can't expel the blood, we essentially get backing up of the blood into the system that basically fills that side of the heart, which would be the pulmonary system. So one of the things that we tend to see with left-sided heart failure is pulmonary edema. We can also see shortness of breath as well, because once again the left ventricle provides the driving force to deliver blood to the rest of the body, and so if we're not able to meet those metabolic demands, then we can have shortness of breath, especially with exertion. Looking at right-sided heart failure, once again we have inadequate function, primarily the ventricle, but it can be the atria as well, except this time instead of being the left side, we're talking about the right side of the heart. And once again, if we're unable to effectively deliver or push the blood out of the ventricles, then the blood tends to accumulate, and so we tend to see backing up of the blood backwards into the systemic vasculature, and so that tends to cause peripheral edema. Now, we can also have right and left-sided heart failure together, where we have essentially both sides of the heart unable to deliver the blood or pump effectively, and so we have a complete inadequacy of cardiac output. The most common cause of right-sided heart failure is left-sided heart failure. So essentially, the left side fails first. We start to get backing up or pooling of blood into the pulmonary system, and then that increases the pressure on the right side of the heart, and then eventually the right side of the heart can't compensate, and so then we get right-sided heart failure as well. Looking at some of the causes of congestive heart failure, when we talk about dilated cardiomyopathies, these are the result of this is basically that the heart muscle starts to, or the heart starts to increase in size, but the walls start to become a little thinner than normal, and the heart tends to kind of balloon up a little bit. Some of the causes of cardiomyopathies can include infarction, where essentially that dead myocardial tissue is replaced by scar tissue that can't contract like normal, or we can get other causes of dilated cardiomyopathy would be due to chemical toxicity, mainly from like alcoholism, or certainly viral cardiomyopathy as well. The other kind of type of CHF that we can get in terms of classifications would be a hypertrophic heart, where essentially the heart muscle, instead of becoming thick, or I'm sorry, instead of becoming the walls becoming thin and kind of ballooning out, we start to see the heart having to work excessively hard, and so as a result, just like any other muscle, it starts to become thick and enlarged. Just like if you were to do 100 bicep curls, that your biceps going to become very, very thick and large, and we lose a lot of the flexibility. And so when we talk about causes of hypertrophic cardiomyopathy, that would be mainly the main cause there would be excessive afterload, essentially blood pressure being too high, so arterial hypertension. Also, if we have to have another cause would be like aortic stenosis, where the outflow tract of the heart is essentially blocked off, and so the ventricle really has to squeeze quite a lot to get that blood to kind of move past that stenotic component. And so as a result, because of the ventricle having to overwork, the muscles become enlarged and thickened, and then the heart really needs to be kind of flexible to kind of work at its best. And so if we have really thick, stiff walls, the heart doesn't really function as well. Also, we can have a variety of heart valve defects as well that can also cause some other or be causes of other types of cardiomyopathies. So as I mentioned, one of the main causes of a hypertrophic heart is hypertension. And so if we look at kind of the cycle of how this works, we have primary hypertension, so high blood pressure, and that's going to increase the stress on the myocardial wall, because the muscle has to work really hard to kind of expel that blood. And so not only do we get an increased oxygen demand because of the overworking heart muscle, but the heart muscle actually responds to the excessive load by basically enlarging or becoming hypertrophic. And then as that worsens and goes on for extended periods of time, that if we overstress the heart muscle enough, we can lead to insufficiency, where we are essentially not delivering the sufficient amount of oxygen to the myocardial tissue. As I mentioned before, that can lead to infarction, or certainly the dysrhythmias, and all those can lead to heart failure. Looking at some of the drug therapies for congestive heart failure, we've kind of broken it down here into the goals of therapy and then the drugs used. And so the two main goals of therapy are to reduce congestion, that means get rid of edema, reduce the fluid in the overall system. That's going to reduce the amount of work or stress put on the heart. And then we also want to improve cardiac function. We want to improve both the systolic and the diastolic function. So that means we want to improve the contractility of the heart to make it a more effective pump. And then we also want to improve the filling component. That's a diastolic function. And once again, as I mentioned before, the heart really works best when that muscle is kind of compliant. It's a little flexible and able to expand and contract really well. It doesn't want to be really thick and congested, like a bodybuilder. We want kind of the opposite, like a well-toned, fit athlete. So if we look at some of the drugs, and we'll talk about these in more detail, the main drugs that we use for congestive heart failure drug therapy would include your diuretics. There's a whole list of different diuretics, different classes of diuretics that can be used. Our ACE inhibitors are one of the main drug categories that we use. And then also our nitrates. Digoxin historically used to be used. We don't see it that much anymore. And then occasionally we'll see some people on phosphodiesterase or phosphodiesterase inhibitors. Here's another list of some drugs that are used for heart failure, and you can kind of see as the systolic function kind of decreases with age, you can see the different gradients. We have normal function, we have mild, moderate, and then severe. You can see a lot of the drugs that go along with that. As the the ventricular function starts to decrease, essentially the CHF is getting worse, then we see the addition of multiple agents. So, initially someone may be on just a diuretic, and then as they start to worsen, they could add in an ACE inhibitor, and then finally towards the end, the really severe stages, then we used to see digoxin. So a lot of the, some of the drugs that we may use, the cardiac glycosides, the phosphodiesterase inhibitors, once again, to kind of increase the function of the heart. Our beta agonists, that's kind of short term once again, our diuretics and our ACE inhibitors. So looking at some of the cardiac glycosides, once again, digoxin is the main one that we see here. It essentially is a sodium potassium ATPase pump, and really what it does is it essentially acts as a positive inotrope, and by doing such, it makes the heart essentially contract more efficiently, and so the heart becomes, it improves the contractility of the heart, primarily the ventricles, and so one of the things that it does, it also improves the Starling function. And so we look at the diagram to the right, and you can see that you can see kind of the normal range of the cardiac output versus the left ventricular end diastolic pressure, and then when we add in or increase the inotropy of the cardiac muscle, we essentially make the heart function better. Now with our cardiac glycosides, they've kind of fallen out of favor with a lot. The other main thing with digoxin is the risk of toxicity. As a drug, it's got a very narrow therapeutic window, and so it was really difficult to keep patients on digoxin at the level that they're at and make sure, or that's therapeutic for them, and not or prevent them from either getting excessively too much or not enough. And so they a lot of patients suffered from overdosing or toxicity. They saw that upwards of 10 to 25% of patients, and if it was severe enough, it may actually cause death. And so with digoxin, it required a lot of monitoring. They did that via blood samples, and the other thing with digoxin is that it had a whole list of drug interactions. And so often with patients on digoxin, because of the interactions that we saw, they really were not good candidates for in-office sedation. The next class of drug we'll talk about are the beta-1 adrenergic agonists. Remember that the beta-1 receptors are primarily found within the heart, and so the agonists, if we increase beta activity, that's going to lead to an increase in cardiac output. Essentially, the heart's going to beat faster, it's going to beat stronger. And essentially, the main issue with these beta adrenergic agonists is that they're essentially limited to emergency treatment. If you think about why that is, it's because additionally, with our beta adrenergic agonists, essentially remember what we have initially is CHF, so we've got low perfusion to the rest of the body, and then so the body's going to compensate by increasing the sympathetic tone. We're going to augment that with our adrenergic agonists. Along with the increased sympathetic tone, obviously you're going to get a release of norepinephrine and epinephrine to kind of compensate or help stimulate that sympathetic tone. And then over time, though, that system's going to kind of compensate by down-regulating the number of cardiac beta receptors. And so essentially what you have is, with a down-regulation, then the epinephrine that was effective before is no longer as effective. Moving on, the next class of drugs we'll talk about are the diuretics that are used in congestive heart failure. In terms of acute congestive heart failure, where the patient's having a rapidly decompensating congestive heart failure episode, diuretics are primarily given like Lasix, in terms of trying to remove as much fluid from the system as we can to kind of help get rid of a lot of the symptoms. So the Lasix is given to help with the peripheral edema that's caused by the acute exacerbation of congestive heart failure. In terms of diuretics being used to help management of congestive heart failure on a longer term basis, more chronically, or chronic management, the diuretics are given, and their main mechanism there, instead of reducing preload, is more to reduce afterload in terms of their antihypertensive action. So things like ACE inhibitors are going to decrease systolic blood pressure or systemic vascular resistance, and that's going to decrease the stress on the heart, and the heart's going to function a little bit easier, a little bit better. Diuretics used to be given in combination with digitalis. We really don't see that much anymore, but the diuretics are still fairly common for CHF. That's one of the main classes that are given in terms of managing congestive heart failure. ACE inhibitors are primarily one of the main tools that cardiologists and physicians use to treat congestive heart failure. And ACE inhibitors are really the only drug that's proven to prolong life in patients with CHF. ACE inhibitors have a couple of different actions. They reduce the sympathetic tone. They also decrease the circulating concentrations of serum epinephrine. And then the other main effect that they have is they actually help kind of reduce the remodeling of the heart, and that can kind of reverse some of the hypertrophic effects that we saw or that we discussed previously. So ACE inhibitors are effectively, in terms of patients with congestive heart failure that are getting dental procedures done, some of the precautions that we need to be aware of are that we need to make sure that we use our vasoconstrictors with our local anesthetics as minimally as possible. We can still use them, we just need to make sure that we take care and don't give more than absolutely necessary. Be aware that these patients are often at increased risk of arrhythmias, and it can be especially prudent to consider perioperative monitoring, even if you're only using local anesthesia, just to make sure that the patient's doing fine. You certainly want to make sure blood pressure-wise, so a minimum of blood pressure, perioperative blood pressure monitoring, and then you can even consider electro or EKG as well. Remember that a lot of the medications that these patients are on can have multiple drug interactions, especially with the NSAIDs. So, if you're thinking about prescribing NSAIDs for postoperative analgesia, you may want to consider verifying with your physician whether or not there's any drug interactions. One of the questions I like to specifically discuss is whether or not sedation can be used in patients with CHF. And I think in looking at this, there's a bunch of limiting factors that at least warrant further investigation. The first thing you want to look at is, how severe is the patient's congestive heart failure issues. If they're pretty well maintained and pretty well controlled, then it's probably fine to do that. Certainly, though, if you look at them and you think they're decompensated and they're having an acute exacerbation, they're actively complaining of shortness of breath, and you check out their ankles and their ankles are large and swollen, and you can't recline them at all in the chair, then probably that patient's not okay to go and really needs to be referred for immediate evaluation by either the PCP or even to the emergency room, depending on how severe it is. The next thing you would certainly want to consider is the depth of sedation. In terms of minimal or moderate sedation, I think that's probably usually fine. May want to definitely proceed with caution, but remember that even with minimal and moderate sedation, we're going to have monitoring perioperatively, and we're going to be giving them supplemental oxygen, which is certainly a bonus. In terms of deep sedation and general anesthesia, certainly in the office, depending on the severity of their disease, I think it can be a relative contraindication, and that primarily reflects the lack of cardiac reserve that these patients have. They simply don't have, any reserve or very reduced reserve compared to a normal healthy person. Moving on, we'll talk about hyperlipidemia. When we talk about hyperlipidemia, essentially what we're talking about is excessive levels of serum lipoprotein. So essentially too much fat is circulating in the blood. And so when we have excessive fat circulating in the blood, that's going to lead to an increase in serum cholesterol, and that's one of the main risk factors for the development of atherosclerosis. Remember that cholesterol essentially comes from two main sources. We have cholesterol that we get from our diet, and then we also have cholesterol that's manufactured by the liver. So if you remember back that there's really essentially four main types of lipoproteins, the two that I'm primarily going to focus on are your low-density lipoproteins. Those are the main carriers of cholesterol, and that's kind of the bad. That's the bad cholesterol that they measure. And then we've got the high-density lipoproteins, which are essentially the good cholesterol, and that's your least atherosclerotic fraction. So that's the part that's least likely to cause, atherosclerosis. You can see from this diagram here the two main sources of lipoproteins. We get lipoproteins coming in from our diet, and then we also get them manufactured from the liver. So if we look at the risk factors that are associated with increases in LDL or bad cholesterol, some of the risk factors, the main one that we see here is smoking. You can see that has a considerable risk. It adds approximately 50 to 100 milligrams per deciliter. We also see hypertension, obesity, diabetes mellitus, especially diabetes mellitus type 2, and then patients that have a family history of early cardiac deaths in the family often have higher levels of LDL as well. In terms of hyperlipidemia management, we can see the two main types of management therapies include lifestyle changes and drug therapy. So lifestyle changes would include things like diet modification, weight reduction, smoking cessation, and certainly anything that's going to increase the metabolism of the body, so increased exercise. Often, though, these lifestyle changes, while they can be effective, just not as effective as potentially drug therapy alone, or certainly if we combine the drug therapy with the lifestyle changes, that's where we get the most bang for our buck. Some of the drug therapies we'll talk about include nicotinic acid, binding resins, fibric acid derivatives, and the last class is the statins. Those are some of the most commonly prescribed drugs that we see in the United States today. We'll start by looking at nicotinic acid. Nicotinic acid has a couple of nice effects. Not only does it reduce the production of VLDL or very low density lipoproteins, it also reduces low density lipoproteins, that's the bad cholesterol. And then it also increases actually production of the good cholesterol, the high density lipoproteins. It does have some adverse effects that can limit its effectiveness. We can see flushing and itching, and it can exacerbate some of the other problems associated with gout, hyperglycemia, and peptic ulcer disease. So these can be some reasons why these drugs are not used with every single patient. Next, we'll look at some of the bile acid binding resins. Essentially, what we're trying to do here is bind the LDL within the GI tract so it's not able to be absorbed into the systemic vasculature. And essentially, by preventing the absorption, then it's effectively removed once it passes through the rest of the GI tract. So it really has no pharmacologic action. It just prevents the systemic uptake or absorption of the cholesterol. So these resins are pretty good at reducing about 25%, up to 25% reduction in the low density lipoproteins or LDL. Once again, we do have some adverse effects that kind of can inhibit some of the effectiveness. The main thing that we see here are nausea and constipation. Additionally, if these medications are combined with other drugs, especially fat-soluble medications, it can prevent the uptake of those fat-soluble medications as well. Next, looking at the fibric acid derivatives, this is like gemfibrozil. The effects that we tend to see here is a moderate reduction in VLDL and LDL levels. Finally, looking at the last class of medications, the statins. These are HMG-CoA reductase inhibitors. And so essentially what this class of drugs does is it limits one of the rate-limiting steps in the production of cholesterol. So with our statins, these are one of the reasons they're one of the most heavily prescribed drugs in America is that they're very effective and they're very well tolerated because they have very few side effects. And they actually do a really pretty good job in terms of reducing cholesterol and LDL. Some of the other actions that statins have, they do have a direct effect on the vascular endothelium. And we also see some stabilization of any atherosclerotic plaques. So anything that's present in the body, it's going to help stabilize those plaques, and it's going to reduce the likelihood of them rupturing and causing a myocardial infarction. And it can also decrease some vascular inflammation if that's present as well. So all these are additional benefits that we see with our statins. So you can see why, you can kind of see why these statins have become so popular. And so with this diagram, you can see the different therapies that are used to manage hyperlipidemia, and you can kind of see where within the system those different therapies kind of act. Next, we'll move on and talk about the perioperative management of the cardiovascular patient and some of the thoughts and concerns that we have with these particular patients. And so remember that just because a patient has a cardiovascular history or some cardiovascular comorbidities, that doesn't mean that they're absolutely unable to receive sedation. In fact, all these patients potentially can be sedation patients. We can certainly vary the level or degree of sedation to match not only the surgery, but also match what would mesh well with that particular patient in consideration with their comorbidities. So, and remember that once again, what we're trying to do is minimize with our sedation. One of the goals is to minimize the stress to the system, especially the cardiovascular system. And so that can be another benefit for these patients that have, a decreased cardiovascular status anyway. And so certainly our goals are some of our main goals in terms of providing minimal or moderate sedation to these cardiovascular patients. One of our main goals is to reduce stress and pain. We're going to do that by administering our, reducing anxiety with our benzodiazepines. We're going to help alleviate pain with our opioid agonists like fentanyl, and then also ensure that we have really, really good local anesthesia. That's one of the main, that's one of the absolute main things we have to do. And we certainly want to administer our local anesthesia, but be aware of the risks of excessive catecholamine. So, we're going to mix and match our local anesthetics ideally. These are some of the patients where I personally really feel that articaine with 1 to 200,000 epinephrine is great for the maxilla, and then on the mandible, I really prefer to use some sort of plain local anesthetic like Polocaine or Mepivacaine, and then you can combine it with your Marcaine with 1 to 200,000 epinephrine as well. So you still get the local anesthetic effects, and yes, you still have some epinephrine there, so it helps with the vasoconstriction, but we just don't need the excessive doses or the higher doses that we normally would give. And so by decreasing the circulating catecholamines, that's going to lead to less stress on the body. So we're kind of attacking this problem from multiple fronts. In terms of the perioperative evaluation of a patient with cardiovascular disease, one of our main goals is to determine the severity and the stability of the disease process. Are they well controlled? Are they poorly controlled? Are they having an acute exacerbation, or are they not? Certainly we want to look at any of the effects of or long-term effects of their cardiovascular issue. As I mentioned before, in terms of perioperative management, the use of local anesthesia is absolutely crucial. We've got to be spot on with our local anesthetics. Otherwise, nothing doesn't really matter what sedation plan we're going to have. It's not going to work very well. Often with our local anesthetics, it's certainly recommended that we minimize our epinephrine. Remember that 0.04 milligrams per visit is the total per visit. That's as recommended by the ADA and Malamed. To help with that, one of the things that I like to do is, as I mentioned before, is to utilize our either plain local anesthetics or local anesthetics with smaller concentrations of epinephrine. So your 1 to 200,000 mixtures, that'd be like your articaine comes that way, and also your bupivacaine comes that way as well. If we're going to exceed that dosage, and I really think it's prudent to monitor the patient, and remember that you can exceed that dose as long as the patient is doing fine, and so you can assess that by monitoring them. And here you can see some of the alternatives to lidocaine. Once again, bupivacaine or Marcaine, and certainly articaine or septicaine. In terms of what monitors I like to use for cardiovascular patients, ideally I like to use at least a 5-lead EKG. That allows me to look at, depending on the monitor, at 2 leads at once. So typically I like to look at lead 2 and then also V5. That allows me to really monitor that left ventricle for any signs of arrhythmias or dysrhythmias. And then we want to make sure that we keep our patients well ventilated and well oxygenated. So a pulse oximeter and then ideally a capnography, or the use of capnography is ideal as well. In terms of administering drugs to these patients, our sedative drugs and our opioid agonists, both of these medications are fine, depending on the severity, obviously, and the degree of the patient's comorbidity. But the one thing that I will advise is that we essentially treat these patients, with some extra caution, and we're going to administer smaller dosages than normal, and we're going to give it ample time to see the drug effect before we start to give more. But often by going slow and titrating in the medications at smaller increments and taking our time, we're able to really get to a level that we want without the risk of, or at least with a minimal risk of accidentally overdosing and stressing the patient. Some specific intraoperative concerns that we have, remember that with hypotension combined with bradycardia, that's especially problematic because we're not able to effectively deliver blood to the rest of the body. And so if we have a patient that's hypotensive and or bradycardic, the first thing I'm going to consider is administering a small fluid bolus. Just be aware that with CHF patients, the last thing we want to do is give them excessive fluid, but they are going to come in having had nothing to eat or drink after midnight, so they can be essentially a little dry. One of the other things that we can consider is that they have excessive vagal tone, and so that can often accompany stress that you'd see from dental extraction or administration of a local anesthetic. So to help with that, we can give an anticholinergic like glycopyrrolate or atropine. I actually kind of prefer smaller doses of glycopyrrolate. It's a little more gentle on the system and doesn't quite increase the heart rate quite as dramatically as atropine does. We can also consider the use of our vasopressors, primarily the two that we would administer here. In this case, essentially would be ephedrine, which is going to increase the heart rate and also increase the blood pressure. We can consider phenylephrine, especially if we had a situation where the patient was hypotensive but had a normal heart rate. Phenylephrine is a vasoconstrictor, and that's going to increase the blood pressure a little bit. And certainly the thing that's going to run through my mind more than anything else is we want to monitor for signs of excessive sedation. So remember, if our goal is minimal or moderate sedation, the patient should be responsive. On the other side of the spectrum, if the patient's hypertensive and or tachycardic, then that's obviously a concern as well, because we don't want to stress the cardiovascular system any more than absolutely necessary. And we certainly don't want to stress the cardiovascular system to an extent beyond what the patient can tolerate. So if in terms of what do I consider or what's going through my differential if the patient's hypertensive and or tachycardic, one of the first things that I'm going to consider is pain, especially if they were normotensive, and then after you start to stimulate them with surgery, they kind of become stimulated and respond accordingly. So one of the things that we want to do primarily or first is evaluate the success of your local. Did you give it sufficient time to work? And then consider either supplementing with additional sedatives or additional local anesthetics. And one of the things that I reach for first is the local anesthetic, because often with pain, the thing that's going to help more than anything else is blocking the patient from feeling that pain, and that's going to be your local anesthetic's job. So once you can ensure adequate local anesthesia, then you can consider supplemental sedatives. Some other things to consider are whether or not the patient's essentially a poorly controlled or uncontrolled hypertensive or has some issues there. And certainly I want to inquire whether or not they took their medications today. For whatever reason, we see this very commonly in the dental clinic where patients will not take their medications even though you told them to. They will forget and they'll know that they're not supposed to have anything to eat or drink, and they'll just assume even though you told them otherwise, that means their medication. So if I see if I ask a patient beforehand and they did not take their hypertensive medication and then we hook them up to monitors and they're above 160/100, for example, and I think it's because they didn't take their medications, then one of the things to consider is certainly rescheduling them and driving home the point that you need them to take their medication on a normal schedule. Some other things that you can consider administering some of the intravenous antihypertensive medications. Often what I tend to prefer more than anything else are these short-acting drugs, and that's because situations in intraoperative situations can change, where we need, let's say the patient's stressed, they become tachycardic and hypertensive at the beginning of the procedure, and then once the local anesthetic kind of kicks in, the blood pressure and heart rate kind of come back down to normal. And what we don't want to do is overreact and give a medication that's going to last for 4 hours. So some short-acting drugs that we can administer would be a short-acting beta blocker like esmolol. We can use a short-acting calcium channel blocker like nicardipine, or you can use a direct-acting vasodilator like nitroglycerin. All right, thank you for listening. If you have any questions, please contact me via email. Thank you.